The companion piece to this in-service is a NAMI monograph or guide that each of you should have received when you arrived. You'll find this booklet to be valuable, an important resource that contains much of the information that we'll be presenting, but it's always good to hear it. As is always the case with NAMI programs, we depend on our lived experience to make our presentations as meaningful as possible. It's what differentiates our mental health education programs from others. It is our desire not only to disseminate important information, but to engender empathy and awareness of the suffering experienced by the young with mental illness and their families. It's very important that we identify symptomatic youth who may be experiencing the symptoms of early onset mental illness. The earlier the identification, the more likely the youth can be connected with the treatment that they need, although, as we will see, there are no guarantees that treatment will be available. And the more likely they are, and they and their families will be spared some of the torment of childhood mental illness. Indeed, it's not hyperbole to say that a potentially lost childhood may be restored if intervention is timely. The following is extracted from our NAMI Basics program of mental health education for parents and other caregivers of youth and adolescents with mental illness. Mental illnesses in children and adolescents are real and can be treated, especially when identified early and treated effectively. Mentally ill youth and adolescents need these supports to avoid losing critical development years that can't be recovered. Research shows that early identification and intervention can minimize the long-term disability of mental illness. It enables children and adolescents to succeed in school, to develop socially, and to fully experience the developmental opportunities of childhood. Research has yielded important advances in the development of effective treatment for children and adolescents. For this to occur, the symptoms must first be recognized, that's where you come in, and then evaluated by a competent mental health provider as we proceed. Peggy will discuss symptoms, Craig will present the family perspective, and Rorik will present the perspective of someone who lived with mental illness while attending school. Please hold your questions until the Q&A session at the end of the presentation, when Judy and Norma from NAMISA, along with Mary from NAMI Pinal Central, will join us for discussion. Let me apply a caveat. It is not our desire to convert education professionals into diagnosticians and prescribers, especially not teachers. We think you've got enough to do as it is. Rather, we simply want to give you some new and we think valuable tools for your toolboxes. Numbers can be dry, but let me give you a sense of the magnitude of the problem. I'll cite for reinforcement some statistics that are found in the monograph. 1 in 4 adults, approximately 61 million Americans, will experience mental illness in a given year in one capacity or another. That doesn't mean they all have mental illness. It could be that they deal with and live with a loved one who has mental illness, etc. Per the Surgeon General's report, 12% of American children under the age of 18 have a diagnosable mental illness. 13% of youth aged 8 to 15 live with mental illnesses severe enough to cause significant impairment in their day-to-day lives. That figure jumps to 21% in the age group 13 to 18. 50% of all lifetime cases of mental illness begin by age 14. The average delay between onset of symptoms and intervention and treatment is 8 to 10 years. That's 8 to 10 years. That means we work really hard to identify youth who are symptomatic, who have symptoms, and then they have to wait 8 to 10 years on the average to get the treatment that they need so badly. 50% of youth with mental illness actually receive treatment. Only 50% of youth who need treatment and who have been possibly identified as people who need treatment, only 50% of them actually receive treatment. Consequences of untreated mental illness are devastating. Left untreated, we may be left with even more difficult to treat illnesses. Approximately 50% of students aged 14 and older with mental illness drop out of school, the highest dropout rate of any disability group. Sorry. So I imagine that's something that you see here, a lot of dropout from amongst the population of children who may be symptomatic. 70% of youth in state and local juvenile correction systems have mental illnesses, with 20% showing severe symptoms. Suicide is the third leading cause of death in youth and adults aged 15 to 24, and that comes after accidental and homicide. 90% of those who died by suicide had an underlying mental illness, usually a mood disorder. Before we continue, let's see if we can agree on what mental illness is. What is the definition of it? We think that they are neurobiological brain disorders caused by chemical imbalances in the brain. And I hope that's what everybody thinks. They are medical disorders just as credible as diabetes or heart disease or epilepsy or cancer. Medical. Brain disorders can usually be controlled by a combination of medication, therapy, support, and a generous application of family and classroom understanding. Note that medication is only one of a suite of tools that we apply. We're not advocating pushing pills down children's throat. Presently, there are no cures, although there is a great deal of active and promising research. Historically, the focus has been on the symptomatic child's bad, and that's in quotation marks, behaviors. And symptomatic children were labeled as bad, the result of bad parenting, especially bad mothering. It's the mother's fault. We have Dr. Freud to thank for these valuable insights. I said there are no cures, but there is the concept of recovery. This describes an individual with mental illness that is able to manage his or her illness, to function successfully in the community, and basically to live a life. They may not be living the life that they started with, or the life that we might even say they were meant to have, but it's a life nonetheless, and it's their life, and they are managing it successfully. That's recovery. Why, we ask ourselves, are mental illnesses in children and adolescents so hard to diagnose? It's because mental illness in youth is a moving target. Until recently, there were no conclusive tests, although a recent breakthrough has identified a promising blood test for depression in youth. And it's difficult to say what is normal or typical for each child. Behavior is scrutinized, but in fact, it is often hard to differentiate between willful behavior and symptoms. Finally, a child's brain itself is constantly changing in ways that impede diagnosis. What's stigma? We hear about stigma. Stigma is a preponderance of negative feelings toward a person or group based on some characteristic that they possess and share. In our case, the shared characteristic is mental illness, and the negative feelings are rooted in a long tradition of ignorance and intolerance. And we hope that part of at least what we do will hope to dispel that stigma. One of the worst kinds of stigma is that which equates our children with their illnesses, and in particular with their behaviors. Dr. Ross Greene puts it very eloquently. He states that while society thinks that children do well if they want to, the reality is that children do well if they can. Most challenged children want to behave the right way. They don't need our discipline and motivation, and they don't want to be on the bottom of the food chain. They would behave the right way if they could, but we have to remember that at worst we have to remember to love the child even as we hate the illness. All my children attended schools in the Washington Elementary School District and the Glendale Union High School District in Maricopa County. Generally speaking, our experiences with the schools were positive. But this is not always the case. Sometimes a family's experiences with the schools are far from positive, and it's hard to partner. One thing is certain. Most of the support of a symptomatic child will take place either in the school or in the home. Parents and teachers are the most intense and skillful observers of our children, and that's why we're talking to you today. and their alliance will often enable the early intervention for which we strive. Note that a positive, trusting relationship between family and school must be built early, not by waiting for crisis to overtake us and then trying to sit down together to work out what's best for the child. Now, we've brought quite a large number of resources with us. I know you know, because you came in those doors, that they're out on the table, and you are intended to help yourself to anything that you may find useful. Certainly, at a minimum, you should go away from here with one of the monographs that contain so much valuable information. We didn't bring any evaluation sheets with us. You're welcome. And equally, hopefully, you'll take a few minutes to think about what you might have said had you said something in an evaluation sheet, which we did not bring. Now, Peggy will talk about the symptoms of early onset mental illness in youth and adolescents. Thank you.
My name is Peggy Kyle. I also am a parent. I have a daughter who is 27, and she was diagnosed with bipolar disorder when she was in high school. Although looking back, symptoms started much earlier. We just had to wait a long time for the formal diagnosis. I'm going to talk a little bit about the symptoms of the various mental illnesses. There's a couple things that you need to remember, or actually keep in mind. You will notice that symptoms are very similar across the board. Something that occurs with one illness may also occur with another. So things are not cut and dried, like this is measles and this is chicken pox. Sometimes the symptoms run together. We're going to be going through the symptoms. We're also going to be talking about what co-occurring disorders we typically see with each illness. And we're going to be talking about what happens at home, what the parents are seeing at home. A little bit about my experience other than just being a parent. I am also a teacher. I'm a teacher of the deaf. And my first experience teaching was in 1970 at the School for the Deaf in Riverside, California. It was a brand new program for multiply handicapped deaf children. And the kids that we served were all deaf, but also had other issues. Now in 1970, kids were not being diagnosed with mental illnesses. They were diagnosed as mentally retarded, or possibly emotionally disturbed. But we didn't have diagnoses for these kids. Now looking back, I realize each one of these kids presented with some type of mental illness or another that is now diagnosable. And I look back and think, well, we did the best we could, but if only I could go back and redo some of those things. Okay. The first diagnosis we're going to look at, also I should say, the monograph contains all the information that I'm going to be sharing with you. So you don't have to take notes if you feel like you need to. You don't have to. Everything is in the monograph. Whoops. Okay, attention deficit hyperactivity disorder. It's a neurobiological disorder, as David said. 1 in 20 children are affected, and more boys than girls are affected. It's not a lack of intelligence or discipline, but an inability to focus. These kids just can't focus. The core symptoms are inattention, impulsivity, hyperactivity, and a low tolerance for frustration. And these have to be present for 6 months and cause disruption in 2 or more settings in order to be formally diagnosed. Now, ADHD in children, hyperactivity. You've seen these kids, you have them in your class. These are the ones that can't sit still, they can't stay in their seat, they're constantly talking out of turn. They just can't seem to focus. They're quite entertaining many times, but they just can't seem to focus. Interrupting when other kids are talking. You all know them. There is also the inattentive type. These are the dreamers. They may not be hyper in terms of activity, but their attention is not there. They're the ones that are out in the field during ball practice or soccer just kind of looking at the sky. They're the ones that aren't being able to focus on what they need to do. They don't like to work in groups. They don't get their work done. They're just kind of dreamy. In adolescence, sometimes we see ADHD diminishing because they're better able to control themselves, not because they are no longer afflicted with it, but because they can control themselves a little bit better. But more than half will continue to have difficulties. The dropout rate is 12 times greater than teens without it. These kids are very likely to drop out because they just can't focus on the work, which is what gets you promoted to the next grade. These kids are at risk for substance abuse and antisocial behavior. A lot of times, as I said, they'll just blow off school because they can't focus, they can't do it. As David said, they do well if they can. They do well if they can. And these kids can't. Co-occurring disorders. Again, over half the kids with ADHD will have another disorder, quite often oppositional defiant disorder, anxiety, or conduct disorder. And 1/3 will have depression. Observations from home. Parents say that there was something off from the very beginning. They never slowed down. These are the kids that were up all night, bouncing off the walls. The parents are exhausted when they were little. They're exhausted when they're older. Kids tend to be in trouble because they aren't doing what they need to do. They just don't have the focus to continue a task. So it's very, very frustrating for parents. The next we're going to talk about is major depression. This affects 2% of children, 8% of adolescents. It's different than adult depression in that the main symptom is not sadness. It's not sadness. What we see are irritability and aggression. Usually it's an abrupt behavior change. We see imagined body pain and a drop in school performance. So these kids, unlike adults, are not necessarily sad. They don't sit around moping. They're angry. In adolescence, there can be very, very sensitive to personal relationships. Overreact to disappointment. There's a high risk of self-medicating. They may stop caring about their appearance. More girls than boys tend to have depression in the teenage years. But they also, as teenagers, they tend to be more adept at hiding their symptoms. A study is cited in the monograph that found that in a screening at a high school, half of the kids who qualified for referral and treatment were not known by the psychiatrists, psychologists, social workers, or teachers in the school. Kids get very good at hiding things. Co-occurring disorders, suicide is a very high possibility. 90% of those who commit suicide have a diagnosis of a mood disorder, as David said. It is the third leading cause of death among adolescents aged 15 to 19. Observations from home. The parents say nothing ever pleases the child, seems to hate himself and everybody else. Quite often, It will be a change. Perhaps early on the child seemed to be well adjusted and happy, and then something happened, something changed, and depression set in. They have a totally different child than they used to have. And again, they put on a good face in public and are usually harder to deal with at home. Oh, sorry, I'm behind here. Okay, now early onset bipolar disorder. The diagnosis for bipolar disorder basically looks at two main things at this point. First of all, a history of bipolar in the family, and an early onset symptom pattern that is unique in children. It's pediatric mania. The child has ultra-rapid mood cycling from explosive rages to aggressive opposition to being upbeat and energetic. Back and forth, back and forth, back and forth. I want to talk a little bit more about this because my daughter has a diagnosis of bipolar. And although she wasn't diagnosed until high school, she did show signs early on, and pediatric mania. I don't know if they were calling it that at the time. I didn't ever hear about it until I started teaching these classes, but she was exactly like that. She would be a wonderful, funny, charming thing, and then suddenly she would be screaming at us for no reason and throwing things and breaking things and very, very, very angry at something what we considered fairly small. We had to take the door off of her bedroom because she was damaging it by kicking it and gouging it with things. So we took everything out of her room too. She didn't even have drawers. Everything was on the floor. Of course, as a teenage girl later on, everything was on the floor anyway. But this was when she was 6 or 7. Life was interesting, yes. These kids have their moments, but they can be charming, funny, entertaining, but they can also be bossy, intrusive, really annoying. My daughter basically showed all of those things. Okay, bipolar disorder in adolescence, for someone to develop this in adolescence, it can be a devastating setback because they're losing so many of the skills that they may have already developed through their childhood. It can strike with great severity, with psychosis, reckless behavior. We see in the depressive phase, crying, moodiness, irritability, picking fights. That was one of my daughter's strengths. She was really good at that. Fatigue and carbohydrate cravings. My daughter was the carbohydrate queen. She wanted bread, she wanted potatoes, she wanted sweets. We didn't typically eat that way, and she would, every chance she'd get, cram carbs. Insecurity, separation anxiety. My daughter hated to do anything new, hated to go places that she hadn't already been to. When she was little, I would have to peel her off my leg when I left her anywhere without me because she refused to be separated. School avoidance, feigning illness, and physical complaints. My daughter was in the nurse's office so often that the nurse finally told her she couldn't come back unless she had a broken bone or was bleeding. Self-isolation, suicidal thoughts and attempts. My daughter did do cutting, but thankfully did never attempted suicide. In the manic phase, actually, she was always kind of fun when she was in her manic phase. A lot of goals, a lot of unrealistic expectations, rapid, insistent speech, lots of ideas, really funny, very entertaining, very creative. But then, of course, it could turn on a dime and go back the other way. Also, hypersexuality. My daughter did get pregnant and have a baby in high school. In spite of our best efforts to prevent it. Lying, making up stories. She did not ever have any psychotic episodes, which we were very thankful for. But everything else, yes. If we had let her have a credit card or anything else, I think we would be without money at this point in time, because she could spend with the best of them. Now, co-occurring disorders. With bipolar, 94% of children with bipolar have ADHD as well. And looking back, I think, yes, that was most likely something that my daughter had, but we really didn't pick up on it. Interestingly, she has 3 children of her own now, she and her husband, and one of her children has been diagnosed with ADHD, but I'm almost sure she will eventually get a diagnosis of bipolar disorder, because she is so like her mother. So like her mother. In many good ways too, but okay, the development of bipolar disorder, again, can involve clusters of symptoms at various ages that look like ADHD, ODD, CD, and depression. Observations from home: ragged sleep cycles, night terrors. My daughter had night terrors from the time she was about 2. Violent rages and tantrums, separation anxiety, and the child acts worse at home than at school. That's very true. Many of the people at school thought she was just wonderful, a model student. It's like, who are we talking about here? The important thing in terms of bipolar is a careful diagnosis has to be made so that children won't be prescribed stimulants or antidepressant medications, because they can trigger manic and or psychotic episodes. So it's important that we know what we're dealing with before we go in with medication. Very important. Another thing, not only with bipolar, but with all of these diseases, teens have an aversion to medications, and especially with people with bipolar, because medication brings them down. It makes them feel less of the person they think that they are. Their creativity goes down, they feel blunted. So medication is not something that they want to do, even though we, standing outside, can look and say, but this is best for you. They don't want to do it. My daughter hid her pills. I was still finding pills years later that she had hidden in her closet or in the back of the bathroom cupboard, here, there. I'm not that great of a housekeeper, I guess you can tell, but nevertheless, she hated taking the medication. Plus, it made her gain weight, which again, as a teenager, is the last thing you want to do. So medications are very, very touchy for people with a bipolar diagnosis. Anxiety disorder. This is extreme discomfort and unease in benign situations, and this is the most common mental illness in children and adolescents. The effects are so constrictive that the child shrinks from contact. A key sign is missing school. They just can't face it. They will find any excuse not to go. The peak onset is mid-teens, usually after a change or a loss. Kids with this are very susceptible to drugs and alcohol to kind of blunt their fear. They know their reactions are excessive, but they're powerless to stop them. Panic disorder, social anxiety disorder, and social phobia are all examples. Now, mood disorders and anxiety coexist at every age. They very much go hand in hand. Observations from home, we can't keep them in school. meltdowns when the parents try to force activities, and the parents feel a catch-22. You want them to go to school to do what they need to do to enter into this activity or that, but they just can't do it. Next, we're going to talk about is obsessive compulsive